representative. And we also have a guest researcher from St George's, Dr. Angeliki Asimaki as well. So I wonder if I could just hand over to the two of them just to say hello. Alan, would you just like to introduce yourself?
My name is Alan Corcoran, and I'm the patient representative presenting today. Please make allowances for me because I'm an old codger, 77, and I've got cancer, so I'll get you on my side, hopefully. Thank you. Make allowances for me, please. Thank you.
Thanks, Alan. You don't need any, particularly for the workshop. You're very good. I'm looking forward to it. Angeliki, do you want to quickly say hello?
Hello, everybody. It's a pleasure and an honor to be here. I'm Angeliki Asimaki, and I'm here to share my experience of PPI involvement in an application I submitted recently with Duncan for funding.
Smashing, thanks very much. And shall I just go through the overview of the session? And well, particularly, let's go through some house rules for today. Would like to encourage you to ask questions. As I mentioned when I logged on, really nice to see faces. I do it myself. I switch the video off when I'm attending something, but actually being on the other end and delivering is always nice to see faces. And if you've got a question to ask, we can be more responsive probably by seeing your hand raised, but do, if you want, raise a virtual hand, put something in the chat. There is a slight delay if you put it in the chat before we may pick it up and read it, but please do bombard us if you want to with questions. We've dedicated, we're going to be ending the session proper, the content of the workshop at about 11:30. We'll have a short break and then come back for about 20 minutes of dedicated to your questions, to questions from the workshop, any questions that you might have come with pertaining to your own PPI activities. So ask throughout, but also come back and ask questions at the end. We will definitely make slides available. Don't worry, we haven't sent them out yet, but shortly after the session today, we will make the slides available. We'd welcome your feedback, and there'll be a link to a feedback form when you're sent the slides. Apologies for any hassles with the registration link today, and but obviously you're here, so you got there in the end. I think that's everything I'm meant to do. The contents on the slide there, I won't run through all that at the moment because, like I say, I'm now waffling and we need to hear from the important guests. So shall we hand over to Alan for the important content and this PPI workshop? Thanks, Alan.
Yes, good morning again. No matter how complicated the research or how brilliant the researcher, patients and public always offer unique, invaluable insights. Their advice when designing, implementing and evaluating research invariably makes studies more effective, more credible and often more cost effective as well. And that was said by Professor Dame Sally Davis way back in 2009. And it still holds good today. I've been involved with patient involvement for over 14 years, and first I thought, how can an idiot like me be helping researchers? But every now and again I think I do something which helps out, and hopefully you'll learn that as well. The patients can give invaluable and credible information to you. So let's move on to our guest presenter. Oh, sorry, I've jumped a slide.
Thanks.
That's terrible. We just practiced this as well. What is public involvement? The NIHR defines public involvement in research as research being carried out with or by members of the public rather than to and about them. It is active partnership between patients, carers and members of the public with researchers that influence and shapes research. So you can get us involved right at the very beginning when you've just got the idea for the research, and it will help. Public involvement is working in partnership consultation, collaboration, is working in partnership, consultation, collaboration, or user control. Public involvement is not sharing information, patients and public as research participants in a study, qualitative research. So basically we just set it out what it is, and hopefully you'll have such a good knowledge of it by the end of this workshop. So we move on to our guest speaker.
Thanks, Alan. Really helpful foundation there. And just to reiterate that definition that Alan's helpfully run through, we're obviously looking at the NIHR's focus and definitions of patient and public involvement. Many of you may be aware that there are other definitions. So if you're looking at other funders to submit your research to, MRC, Wellcome Trust, they have a slightly different definition. So we're working towards the NIHRs today. But if you want a question about that, that's absolutely fine. So, Angeliki, welcome again. So I'd like to introduce Dr. Angeliki Asimaki, who's kindly come along today to talk about her research and how she's undertaken some patient and public involvement ahead of submitting her funding proposal. Angeliki is available to take questions at the end of this presentation, but she'll also be with us for the whole workshop, including the Q&A right at the end that I mentioned earlier. So, Angeliki, over to you to introduce a little bit about yourself. Thank you.
Well, thank you very much for the invitation and the introduction. To give a little bit on my background, I am a senior lecturer in sudden death. I completed my studies at Queen Mary University of London, and then I moved to UCL to do my PhD. During my PhD, I was offered an opportunity to spend 3 months at Harvard University in the States, and those 3 months turned into 11 years of my life. So I completed all my training at Harvard, and then I moved back to London in 2017 to take on a faculty position. Now, as my title indicates, I work on diseases that predispose young people to dying suddenly, and I have a special interest in arrhythmogenic cardiomyopathy, that is a heritable heart disease and one of the major causes of sudden death in all populations of the world.
Thank you. So what background, Angeliki, do you have or previous experience in patient and public involvement?
So what I would like to share with you might be upsetting for some people. This is my personal story, and I'm not sharing it to upset you. I just want to get you to understand how I ended up having that scary title or being involved in that job in the first place. So I was born with 2 different congenital heart defects. The chance of somebody being born with 2 different heart diseases is about 1 in 2 million. I was diagnosed with an AV block when I was 14. That means my heart cannot conduct electricity from the upper to the lower chambers. And I was fitted with my first pacemaker. Then I'm using my batteries quite a lot. So I'm currently going through my 5th generator. When I was 19, I had a pulmonary embolism, that is a clot in my lungs without an apparent reason. When I was 25, I had a stroke, that is a clot in my head without an apparent reason. And 4 years later, I was subjected to a frontal lead extraction, that is a big surgery to remove pacemaker leads that are not working properly anymore. And it was during this surgery that the surgeon discovered a gaping hole in the wall separating the right from the left part of my heart. And so that essentially was the reason that I was getting all these blood clots. So I had, in 2011, I had an open heart surgery to stitch that hole up. And then a few months after this surgery, I developed pericarditis, that is an infection of the sac surrounding the heart, which was nice enough to stay with me for 18 months. And when it finally resolved, I developed atrial fibrillation, a very abnormal heart rhythm. So now we go to 2014, and at that point I was having 200 episodes of atrial fibrillation a day. Then it was time to start the ablation surgeries to eliminate the substrate that was causing this abnormal heart rhythm. I had one of these surgeries, it was unsuccessful. I had another one, it was also unsuccessful. And then finally I had the 3rd one, which worked. And I have been arrhythmia-free since. Now the remnant of this hole being discovered way too late in my life is that now one of my valves has failed. So I have to live with heart failure. So as it might be evident by this point, when it comes to heart disease research, I'm not working for the patient, I am a patient. For me, PPI is not just a tick box component of research, it is personal. And at this point, I need to say that today I'm not here as an expert. I'm actually very new to PPI, but I was very fortunate to meet Duncan, who has taught me a great deal over the past few months and got me seasoned enough to be able to incorporate PPI in a rather complex study.
Great, thank you, Angeliki. And thanks for sharing your personal story. Could we move on now, and could I ask you to briefly summarize the research that you've recently submitted for funding?
Absolutely. I'm going to share some slides with you so it makes a little easier to understand what I'm working on. So if you bear with me for a second, I think. Can you see the slide?
Yes, thank you.
Brilliant. So the disease, arrhythmogenic cardiomyopathy, for abbreviation, I call it ACM. So although people with ACM, so first of all, before I start on the research, the work that Duncan and I did was in preparation for an application for an NIHR advanced fellowship. Now, patients with ACM are born with DNA change, but still the disease shows its first clinical signs around early adulthood. And this is what we call the disease onset. However, we do not at the moment know when the disease is going to strike. And if somebody has lost a family member to ACM, they are invited to the hospital every year to undergo multiple clinical tests and monitor for possible disease onset. Additionally, the disease might be stable for several years, but then undergo a flare-up that is called the hot phase. And these phases are associated with the highest risk of sudden death, and they require timely and accurate management. So our aim is to improve our ability to predict disease onset and subsequent hot phases and essentially minimize the risk of sudden death. In our previous research, we showed that a number of proteins in a normal heart depicted by these white little lines have moved in the heart of somebody that has ACM. Now, this was very helpful to establish a post-mortem diagnosis of ACM in somebody who had died suddenly, but it was not particularly helpful in people that were still alive since it required a piece of their heart. We managed to circumvent this obstacle and showed that the same proteins that are relocalized, shifted in the heart of ACM patients also do so in the buccal epithelium, that's the inside of their cheek. So we can diagnose a deadly heart disease by essentially rubbing a soft brush at the inside of somebody's cheek. Now, we followed a small number of pediatric patients, of children with ACM over 7 years, and we showed that a group of proteins only moved right around the disease onset, while one additional inflammatory protein only moves right before hot phase. So now we need to expand these results into a larger adult population and essentially develop cheek smear analysis into a risk-free and non-invasive prognosis test. So the study that we submitted for consideration has two objectives. For the first objective, we need to recruit 180 adults that carry a mutation predisposing to ACM, but do not yet show clinical signs of the disease. So that's before the disease onset. Now, the participants will be approached by dedicated research nurses at their regular annual hospital appointment. The nurse will explain the study to them, consent them, and then obtain their baseline cheek smears. And to spare the people from additional burdensome hospital appointments, we have developed a do-it-yourself kit that allows people to obtain their own smears and then post them to St. George's for analysis. And we have also developed a video on YouTube that can help guide the whole process. So the agreeing participants will be invited to obtain their own smears and post them to us every 3 months for the following 4 years in prepaid envelopes to be provided. The nurses will send text message reminders to the participants to get them to send their samples in, and they will also be available to answer any questions or share any concerns throughout the duration of the study. For the second objective, again, we need 180 participants, but this time they need to already show clinical signs of the disease. So this is after the disease onset. Again, they will be approached by the nurses at their regular annual hospital appointment, who will consent them and get their baseline smears, and then they will be invited to get their own smears and post them to us every 3 months for the following 4 years. Now, people that are actually undergoing a hot phase might greatly benefit from anti-inflammatory medication that is already available. The problem is that these drugs can have a lot of side effects if given chronically. So to me, it is very important to figure out how this additional inflammatory protein I briefly spoke about, how long does it remain mislocalized after the resolution of a hot phase, because this can help accurately guide the time frame of effective and safe medication. So with that in mind, if somebody undergoes a hot phase over the duration of the study, then they will be invited to post samples to us every month over a period of 6 months. And if we see that there are changes in proteins in smears that patients have posted to us, then we reserve the right to bring their annual regular appointment forward, as this will help us validate our findings and also manage our patients in a more timely fashion.
Great, thanks, Angeliki. So can you highlight how you undertook some early patient and public involvement work for this research?
Absolutely. So the first step is to basically engage with an RDS advisor. If you are at St. George's, talk to Duncan. If you are not at St. George's, find the Duncan of your institution and do this at least 3 months before your application deadline. Now, in my case, Duncan advised me to first apply for an RDS London Public Involvement Fund. He will talk to you more about it a little later, but this is essentially a fund that you get to reimburse or thank the patient for their time in your PPI activities. Now, there are about 60 patients with ACM followed at St. George's. They are part of a WhatsApp group, which is led by Katie Frampton, a research nurse. And it was through this group that we found 7 patients that were interested in consulting with us. So we met online in early June. In preparation for the meeting, we prepared a list of questions to be used as a discussion aid. The session lasted for an hour. At the beginning, Duncan shared a few slides with the patient on what PPI is. Then I showed the patients the exact slides I just shared with you, and I explained the study in exactly the same way I did with you. Now, our questions could be either fairly general, like, do you think the research is useful? Would you be interested in becoming a member of the project advisory committee? Or more technical, such as, would you be okay to obtain your own cheek smears? What do you think about the frequency that we ask you to send us your cheek smears? Would you be okay if I was to bring your hospital appointment forward if I was to find abnormal results in your smears?
Great. So what sort of feedback did you gain from your PPI group, and how did it help shape your proposal?
So first of all, both Duncan and I were quite happy with the way that this session went. And later on, we heard that the patients also fed back in their WhatsApp group that they loved being part of this consultation as well. Now, a few of the points we were able to incorporate in the proposal, and we feel it significantly strengthened it. Like, for instance, based on the PPI feedback, we now propose that our nurses undertake mental health training so they can signpost the more anxious patients if necessary to obtain the support they need. And this is a direct result of the feedback from members of the group about how the study might raise anxiety for a group of patients who may already be quite anxious. Also, based on the feedback, we will now advertise the study through posters in the hospital so patients can familiarize themselves with it prior to being approached by the nurses. We also realized that one PPI member did not know what a hot phase is. And I was quite surprised about this. It made me think that I cannot assume that patients know everything, even if it is about their own disease. But that feedback, however, made us change our participant information sheet to include an explanation of a hot phase. And we were also able to include verbatim patient quotes from the session in the proposal. For instance, when I discussed the second objective and I asked the patients, would you be okay with the increased frequency? I mean, getting your smears and posting them every month for 6 months. One patient said, you can swab me every week if you would like. And this phrase I actually incorporated in my grant. Now, there were also suggestions that were great, but couldn't be incorporated in the proposal at this stage. We still included them, and we also said why we couldn't act on them at the moment. So, for example, one member suggested that we screen potential participants for anxiety before recruiting them. But we felt this could discriminate against those people that are a little bit more anxious. Another member said we should recruit everybody at exactly the same time so they all benefit from the study on the same way. This was a very good point, but again, I think that the NHS would not have been particularly happy with me had I asked for 360 appointments in a week at the same time.
So were there any unexpected issues that came up for you when undertaking this PPI work?
So one thing we did not anticipate, and it is good for researchers to know, is that PPI consultations can create anxiety for patients. So although ethical approval is not required to assemble such a group, researchers should make sure that they conduct the PPI sensitively and ethically. We also did not anticipate that researchers or other members of the public attending the PPI session may be aware of things regarding a disease that some patients themselves are not aware of. And this can bring the researcher and the patient at a difficult position. Now, in our case, when I found myself explaining what the hot phase is, I felt I had to tone it down quite a lot so as not to scare the patient. In the future, when we conduct this again, we will explain what a hot phase is when we introduce the study to make sure that everybody is on the same page. So the take-home message is do not take for granted what the group already knows.
Yeah, good point. So when do you hope to hear back about the funding submission, and how do you plan to keep in touch with your group of patients?
Well, first of all, I expect to hear whether I have been invited to interview states in early December. And after this date, I will hear whether I have been successful in securing the fellowship. I will stay in touch with my PPI group and I will let them know the outcome as soon as I know. And in addition, we plan to email them and let them know how the session actually helped shape and improve the proposal with some examples like the ones I just shared with you. And I will also explain to them why some of the feedback was great, but we couldn't incorporate it. And honestly, the biggest piece of advice for someone who is new to PPI is to find one Duncan quite early on. Like, to me, this was the key, since Duncan pretty much guided all the rest. But also researchers need to really explain things in very lay terms, be quite empathetic, prepare a lot in advance, and make a real effort to incorporate everything they hear from the patient in their grant, and then communicate back to the group what has changed as a result of their input.
Fantastic. Thank you, Angeliki.
Thank you.
And for your kind comments. I didn't pay her to say those things. Yeah, really interesting. As I mentioned, Angeliki is available throughout the workshop, including at the end. We can take a few questions now, though. Just 2 points that I'd like to pick up on while people think about the questions, and either put that in the chat or raise your hand. Two things that stand out for me in Angeliki's sort of example there is it's obviously a highly complex piece of research. Put it very simply, and I'm often asked or confronted with the question from researchers, oh, it's so complex, it's not possible to involve members of the public. And I think this demonstrates quite clearly that it is possible. I often get this with sort of lab-based type technical research and also very highly statistical research. So don't be put off if your research is highly technical. Jump in, do have a go at involving members of the public because they can help shape your research. And I think another thing that jumps out for me too is Angelika's good example of feeding back to the members of the public what could not be incorporated. Do incorporate the things that can, but maybe also give an example, either in the proposal or when you feed back to the members of the public, what couldn't as well, because not everything can always be. Okay, are there any questions that we can take straight away for Angeliki? Just got some thanks in the chat, great example. So thanks, Angeliki. And again, thanks for sharing your story. Okay, I can't see any questions straight away, although something's just appeared. Sorry, I can't move very quickly between the chat. Oh gosh.
We read that.
It's so small, I can't read that, Ines. Sorry, Rona.
Sorry, I may have missed this, but what changes will we see as RDS is replaced with RSS?
I'll cover that shortly, if I may. Towards the end. It'll also be summarised in the slides, so you can always come back to me if you're not if you missed that bit. Okay, let's continue with the rest of the workshop, and it's now back to Alan, if that's okay, Alan. And you need to come off mute, Alan, sorry.
Very
got too comfortable.
Very professional, yes. Still on. So the next slide for me to look at is who are the patients and members of the public? Right, here we go. Who are the patients and members of the public? Anyone who is lay to the research in question. These are the members of the public. Sorry, mine have got a little box covering up the slide. So patients and survivors, carers and family members, members of the public, community groups. Also included are people with the lived experience. This is, you might hear this quite a bit, the lived experience. So PPI came out of the no decision about me without me. It's a kind of democratic inclusion of everybody who's involved. Instead of things being done to patients, they're involved in it and become part of the cure, if you like. Also included are people with one or more health conditions. So some of us have got quite a few comorbidities, and so every patient is unique. So it's very good to get a cross section of people involved. Now, I think that covers everybody in the world, you know, and patients, survivors, carers, members of the public, community groups. So you're probably doing a PPI all the time. I mean, you're talking to your husband, your wife, your mother, your father, your children, depending on what age they are, you know, and you might be telling people what you're up to, and that is PPI work. And what you've got to do is kind of write down anything anyone says about the research, and that will add to your PPI sort of portfolio, where you can quote what somebody said about it. And basically, you're just putting it out there and getting feedback from people. So patients and public who have involved themselves in helping in research. Once you start to get PPI people like myself, we're on your side. We want you to succeed. I was an engineer for 30 years, and I was a telegraph engineer, so I did electromechanical stuff, and I wasn't really helping people. So a lot of you researchers are very, very lucky, because you're helping people all the time. So you feel better about yourself when you just fix a machine or, you know, find an electrical fault. You feel good about it, but it's not the same as being involved with people and making a difference. MAD. I do like the idea of making a difference. So I am a little bit mad. So there we go, MAD. And we're on your side, as I said. So when I read research, I read it very slowly and purposely, because I'm dyslexic. I don't like to move on if I don't understand it and something. So sometimes I see things that are blindingly obvious to me. When I used to present 7 years ago, when I started doing this, the public involvement workshop, I came up and I put my glasses on the top of my head like that, and I come up and I had my notes in my hand like this, and I thought, oh, what have I done with my glasses? Now, everybody in the room could see I had them on the top of my head, but I'm looking on the seat I just stood up from. So sometimes members of the public and patients, once you involve them and they're going through things with you, they can see things you can't see. So please involve members of the public in your research. So basically, what else have I got here? I mean, I think I'll move on to the next slide, because the next bit I've put here really covers from the next slide. Why should you involve patients and the public? It's access to privileged lay knowledge and the lived experience. Because you might not, I mean, in this case today, our researcher has a lot of knowledge because she is the patient and she is her own PPI in a great many ways, which is wonderful that she personally involved and she knows the problems, and she's actually feeling the problems, because research can be a little bit pedantic and looking at it and dotting the I's and not getting some emotional input. one thing when you get patients involved in your research, it becomes a little bit messy. I'm a little bit of a messy person, and you never know where it's going to go, which is good, because research should be that way. It should be you understanding as well the democratic principles, the right to say what and how publicly funded research is undertaken, an intrinsic part of citizenship, public accountability and transparency. It can lead to people providing a route and influencing change in issues which concern people most. So it will make your research better. Research quality and relevance. Public involvement provides a different perspective. It raises ideas, issues that you might have not considered. Public involvement can improve the quality of research and using accessible language, acceptable methods, and increasing recruitment and participation. So I've had researchers that have got brains bigger than my room here I'm sitting in, but they happen to be German, and they started to explain in a lay presentation what their research is about, and one sentence went on for 5 lines, and as a dyslexic person I lost the will. I'd forgotten what it was all about when I got to the end. So as a dyslexic person, I want you to know that the Metro and the Sun newspapers, which happen to be the most widely read in Britain, aim for a reading age of 9 years of age. So basically you've got to bring the people with you. So make it easy. So short, sharp sentences which say something and the person stops and thinks what they've just heard. And that gets it through to people. So I will help, if any of you want some help with your lay presentations, you can send me your research and I will look at it, and your lay presentation, which you put at the beginning, and I will rewrite it or add in different colour print what I think you should say to make it more accessible to the people that it's aimed at. So what have I got here? So sometimes your research is your baby, and when people say it's a bit ugly, you don't like it when they're talking about your child that you love and you've put it together and spent a lot of time on. But sometimes when people point out something, it can make it better. And as I say, we're on your side. So please use us, because we want to be used. And so please use patients and public in your research. So could we have the next slide, please? So, how do we find members of the public? Well, with most illnesses, if you happen to be a clinician, there's support groups for this, and there's loads of connections you're going to find from Duncan and the RDS. They're going to give you loads of links, and I happen to work for, since 2009, something called the South East London Cancer Research Panel. But we're not just for cancer. We changed it at one time to South East London Consumer Research Cancer Panel for Cancer, but it was just getting too long-winded. And there's about 28 of us, and you can practice presenting to us as though you're claiming for your financing for your research, and listen to what we feed back to you, and hopefully we will help improve the chances of you getting funding. As I say, we're on your side, and there's no cost involved in this. We're all volunteers, and we all want to help. Like myself with my cancer, I'm only alive now because of researchers found cures they didn't find a cure. They found out what was causing my bone marrow cancer way back in 1986 in Philadelphia. They found out what was causing it, and since then Big Pharma has been working on my cancer, and and getting lots of things that will keep it in check, but it does mean that I've still got the cancer all the time, which might be a good thing, because I understand people relax a little bit when they're completely cured, and then they go into a bit of depression. So you can find members of the public. If you with children, you might want to go to schools, social media, publicise. There's a couple of links here, and the chain one is great for you as well, but not just for finding patients and public to help in your thing. I get loads of work from it, and I've just been recruited by Research for Patient Benefit with a 24-month contract to look, and so I'll be handing out, well, I will be a member of the committee, which allows, we've got 50 million to give away to researchers. So hopefully you'll come through to me and I say, oh yes, I remember you from this, and I'll try and help you. I want you to succeed. So I feel that now I'm not a bit of a waste of space, you know, not contributing to society, because I've involved myself with people and trying to make a difference. Perhaps we go on to the next one, please. What is the difference between, sorry. Oh, what slide number is this? Slide number 9. I've jumped a little bit, I've missed out one. There we go.
Number 9, that's right.
Yes, I've got it. Right.
Well
yes, I'm going to give a little example after this. What is the difference between tokenistic and real public involvement? Well, bad practice is treating involvement as a tick box exercise. We all, you think, oh no, there's another thing I've got to do before I can start my research properly. This is just another thing slowing me down, getting in the way. And I don't want you to treat it as a tick box exercise. As I do say, treat it as an opportunity to make your research a little bit better. Being close, bad practice is being close to patients and public's perspective and just treating it as a tick box exercise, not following up with patients when they've been involved. Try and get back to people if they help you a little bit, because they'll want to know that what they're doing is not just talking into thin air. So it's really nice to see those who've put their faces on, so that it's not just I don't know, it's my ex-wife, you know, holding up daggers towards me. Involve them is not having no clear rationale for public involvement, no plans, so they seem to be an afterthought. I'm going to give you a little example of that. When I was on the CELCRAP, South East London Cancer Research Panel, they an anaesthetist at Guy's Hospital came in and presented to us her research, and she used to put a parabolic block, which is radioactive. When people was having a lung removed, it was obviously a painful and long operation. So she used, before they sewed the patient up, they put this parabolic block on, which would numb the pain and just dissolve this radioactive block, which deadened the pain. And she suddenly thought, I wonder what would happen if I put it in a couple of days beforehand and then put another one in, because there is radiation involved, but it's tolerable, you know. And so she opened, the patient was open, they put in a parabolic block, and it was a great success. The patient had hardly any pain at all and went home 2 days earlier. So this was a win-win situation. So she told another anaesthetist, who happened to be a woman, and she did the same. And then they started doing it, and they wanted to roll this out for the whole of the country. And you know, you just can't do things like that. You have to show that it works, and you have to have blind tests against some who've had it done and some haven't had it done. so she presented to us, and she happened to present it very late, and they said it had to be in by the Friday, and it was the Friday that they sent it out. Well, I happened to be up that evening, and I said, this is a no-brainer. Everybody benefits from this research, you know, it's just great research. But she's got another job, you know, she's an anaesthetist. She wasn't involved. She had to make up the application for funding, and she was getting involved, and she'd left it to last minute to get patients involved. And then 3 months later, the research comes to me again in an email, and I said, I recognise this. I've already said this is a no-brainer, because I like to use colloquial language, because you're talking to clinicians when you know, sometimes they're using baffling medical words to me, and I have to go to the dictionary to find out what's going on and put it into lay people's language. So I was really upset that this research had been held up for 3 months because she'd left it to the last minute. So don't treat it as a tick box exercise and leave it to the last minute. Get in early with the patient involvement. As I said, it's quite easy. All you have to do is talk to people. But finding the right people, Duncan's going to help you with that, give you loads of places to go and where to get it. So the good practice is inclusivity, making sure researchers' questions reflect the needs and priorities of patients and the public, making sure the methods and procedures are feasible and appropriate, making sure information is relevant to and accessible to those being recruited to the study, identifying dissemination channels relevant to the patients and public, and developing outputs that are acceptable to a lay audience. So it is that lay presentation which I find, try not to just copy and paste bits of your research into the front bit, which often happens. And if you're going to say that the cancer's metabolized, you've got to say spread to other parts of the body. We're not all clinicians. And when I was an engineer, I'd say, well, there's a dis or a short circuit, or there's a earth on the A line or something like that. And we get into language and abbreviations. And so try not to use many abbreviations. The inclusivity is to bring people in. They don't want to be baffled by things. So try to spell it out to people. So let's, so I've told you that story. So so involve patients early. What kind of research benefits from the public involvement? All research benefits. It doesn't have to be clinicians or, you know, just research on oh gosh, yeah, sorry. I jumped a little bit ahead. I was gonna which kind of research? It can be more obvious to see benefits of public involvement in research with direct patient contact. So if you present to us, you know, in the South East London Cancer Research Panel, you might want to say, is anybody would like to join my research who has knowledge of the research I'm doing and come in as a co-presenter, you know, co-person in the research to be included in. I've got loads of jobs, and sometimes, you know, you spend a whole year involved in somebody's research and you become part of the team. And then when they don't get the funding, perhaps it's too ambitious, it wants to go national straight away, like one of them I was involved in. And I thought, oh, this has been a whole waste of a year. And then the researcher wrote a book on what not to do and how better to present your research to get funding. So she became a published book person, and so it added to her profile, and she became a much better researcher. All research, I mean, you think, well, lab-based research, how can you possibly involve patients in that. Statistical research involving big data and artificial intelligence. How can you benefit? How can that be involved with the patients? Well, there's two answers to this. When during COVID, my career as a patient and public involvement really took off. I'd never had any Zoom calls or Teams meetings, and suddenly the hospital had lots of data, and a registrar at King's College Hospital noticed that a lot of overweight people and a lot of ethnic people seemed to be dying with COVID. And she said, I need to get this out there. I need to look at the data. Well, the data in King's College Hospital has been collected on computers since 2000. So they had all the weight, you know, the BMI of people, what they came in for, whether they died, lot of thing. But the data belongs to King's College Hospital. They took it, but it also belongs to the patient. And she came through and she wanted to use this data, and I'm on the committee for King's called KERI, King's Electronic Research Initiative, you know, yeah, KERI. And she said, she put not applicable in the patient and public involvement on our pro forma. And I said, they're going to bring you up on this. So use me, and I'll give you a load of references to work I've done underneath to say that I've okayed this and put it through. That's all it's a technical thing, getting your funding. Don't get tripped up. We're on your side, the patients. Use us. And even when it's big data. And then I got a job with an American company matching cancer patients to experimental cancer medicines when they'd been given, you know, when they got 4-phase cancer and there's sort of no hope, and experimental cancer medicines, when this first started out, when there was only 4 experimental cancer medicines for the whole of Great Britain, 1 in each capital, you know, in Edinburgh and Cardiff and London and Belfast sort of thing. And I was the patient on this group. And so I sat in on these meetings, and all I kept doing was referring it back to how that's going to benefit the patient. Then I sort of said to, I'm with the top surgeon for King's College Hospital and a health researcher. I said, how can he check that the artificial intelligence has made the right offers of how to treat the patient? Because we tried to match it to the process of going through the hospital when we get to giving the patient the treatment, you know, the Teams meetings about the patient and things like that. And I said, he needs to know that he hasn't made a mistake. Can he interrogate it? And the meeting went on for another hour after that, which I thought, I shouldn't have said that. But you've got to bring it back to what it's for. Hopefully it's to prolong life of the patient and to give much more life to the patient, because we're all going to die. But if we can give another 40 years of life to somebody and see them live out their life and have their loves and everything else, it's very worthwhile. I'm going to give a little story. I was, as I said, I had a bone marrow cancer, and I was retired, and I was wanted to get my peace dividend. I booked a flight to Northern Ireland to see all these things I'd heard in the background to my life with the troubles in Northern Ireland. And I was going to go around Inniskillen and these sort of places in Northern Ireland and so, kind of meet the people, if you like, in Northern Ireland. I booked a flight, but I'd had this sore throat. And so I went to my doctor. I said, could I have some antibiotics? And she said to me, I think it's going to cure up. It's a very mild infection. I said, well, I thought that 6 weeks ago. And she said, 6 weeks, oh, you're over 60. She said, I'll send you for some tests. And then I was going on the Monday, and that was on the I was going the next Monday, and that was a Monday at the doctor's. So the Tuesday morning, I gave some blood at Dulwich Hospital, and when I came home from work, I was still working then, at 5 o'clock on the Friday, the phone was ringing, and I picked it up, and a nurse said to me, "We've made an appointment for you Monday morning at King's College Hospital." I said, "Oh, I'm afraid I'm in Belfast then. I've booked a flight, and at the youth hostel, I booked in there, and I want to." And she said, "Well, I'll have to put you on to Professor Mufti." And Professor Mufti, I explained to him that I'd booked, you know, can it wait for a couple of weeks? I'll be back within a week or two, you know. And he had to tell me on the phone he thought I had the bone marrow cancer. I said, "Well, I think you're wrong, but I'll cancel it," you know. So I cancelled it and went along on the Monday morning, and they took some bone marrow off me, and they said, "Come back on the Wednesday." So I went in on the Wednesday, but they said I had to take someone with me. And so I took someone with me, my girlfriend at the time, and she's a computer programmer, so she was very good, because soon as they asked, they gave me an appointment at 9:15, and at 12:15 I was climbing the wall. She'd taken half a day off work, and I was nervous anyway. And then Professor Mufti came out to me, and he explained that if someone hadn't turned up for appointment, I would have put in, because he had to talk to me. And he was explaining I had this bone marrow cancer called chronic myeloid leukemia, and it was a good cancer. And I'm thinking, good cancer? My mother was dead within 6 weeks of being told she had cancer, you know. Never heard someone say good cancer. And he said lots of research, but I was putting my affairs in order. But my partner, she was writing down all the things that he was explaining. Then he did something really wonderful. He'd asked one of the patients to stay back. And so he took us out to the waiting room, and a lady called Penny was sitting there, and she was sitting there. So she said, "Oh, I've got your cancer," she said, "and I can tell you some of the things that you have to do, and some of the wangles, and I've got the T-shirt, I've been there, so you don't have to make the same mistakes." And I said to her, "Well, how long have you had the cancer?" And she said, 8 years. 8 years. I said, wow. So I love this lady. I relaxed straight away. 8 years. I've won the lottery. As far as I was concerned, this patient had more effect on me than this kindly avuncular professor. And she started telling me, and I love this lady. She's my new best friend, because she gave me 8 years of life. And then I'd already booked 6 weeks' time going with my partner to Australia. And Penny told me how you can get checkups and things in Australia. And it was all arranged with my specialist cancer nurse, which I didn't know anything about. It was all a big learning curve. So I went off to Australia, and I could get the cancer checked while I was there, that it was responding to treatment. And it's a wonderful cancer to get. If you're going to get a cancer, get my one. I take pills every day, oral cancer medicine, and it's just wonderful. And and it's been a career move for me. While I was in Australia, I was thinking, why, when I've spoken to other people, when we started, I got involved with starting a support group for my people with my cancer in Kings. So I was a founder member of that. And people said that they cried for 3 days and they went into a depression, you know, that everything was a waste of time. And so I thought, well, if everyone should have a penny. So the penny dropped for me, and I wrote a slip out, and I was going to go to the clinic every week and give out a slip of paper to people. I've got your cancer. If you've got chronic myeloid leukemia, you need to contact me. You can have my phone number and we chat about it, and I can tell you some of the wrangles, and I'd help them. It wouldn't make any difference to their clinician's treatment, you know, the medical treatment, but the well-being of the patient would be a lot better, the anxieties and all of that, because I didn't suffer from any of this problems. So the patient often can do things that you can't do. You know, it's just amazing. When I started on a drug called Gleevec, and Gleevec was a wonderful drug, and it brought down the 100% mutations of my white blood cells to 12%. But that wasn't good enough, they said. And they said, oh, well, it went down to 3%. And that was wonderful. And then the next time I gave blood samples, it had doubled to 6%. And the next time I gave blood samples, it had doubled to 12%. They said, would you like to go on a drugs trial? And I said, gosh, yes, you know, because they said that's what was needed. Now, the drug hadn't been okayed by NICE. So NICE is the National Institute for Clinical Excellence. And I'm sorry if I'm waffling on a bit, but when I found out, so I took this drug and straight away it went down to below 3% and stayed there. And then it started to creep down till at the moment it's 0.032% of my white blood cells. So my immune system's working all the time. So I'm a little bit vulnerable to COVID and things like that. So I'm vulnerable to it. So, but I could do something for the drugs company that as a patient, they couldn't do. I managed to start a petition on the government website to advertise Big Pharma, which is not allowed. So I don't know whether you can see that. I'm on the front of the local paper saying, why can't everyone have this drug? They priced it at 31,800, and a life apparently for NICE at that time, back in 2007, was worth 31,000. And once it went over that, it wasn't worth anything. You know, putting research in, there has to be a cut-off how much you spend on patients. And so I managed to get it onto their drug. Got a load of advertising. And there I am, a younger me, on the front of the paper, but a new shopper in that case. So you never know what patients are going to do for your research and how their involvement's going to be. It's research. So if you knew all the answers, it wouldn't be research. Please use the patient. So that's basically it. My story, 2 stories in that involved, and I went on a bit waffling. I do get a bit waffly, so stop me if you've all fallen asleep. I'm sorry.
It's fine, Alan. That's good. It's all good to hear. Thank you.
Yep.
Should we move on to the research cycle?
Yes, let's go to the research cycle.
Super. It's still you, Alan, unless you want me to kick off with some examples.
No, I can kick off. I can say a bit about any of this area of research. But basically, I've mentioned involving the design of something, getting the patients involved early. It's just a matter of asking. And people say, well, how do I get patients and public? Basically, ask. As our wonderful presenter today said about her research into the sudden death thing, people want, you know, they want to be involved, and they me, you know, I pull back my shoulders and think, oh gosh, I'm not a waste of space. I'm helping someone. You get something out of it, you know, when you give something away. And like your research, like love, you know, it's a bit useless on its own when it's your research and you're just looking at it. The more you spread it about, the more you get back, and it's like love, as I say. It's much better when you involve someone else in it. So that's the design at the very beginning, and perhaps dissemination and impact. Well, Duncan's going to give you lots of information about the dissemination, but don't hide your light under a bushel, as they say in the Bible. Make sure the results are widely disseminated throughout the formal and informal networks. Jointly present the findings. You know, ask your patients to become a co-author. You know, if they've given you something that's changed the design of your research, like when it's not clinical kind of research. I work a bit for the Cicely Saunders Institute into the hospice movement, and it's a bit emotional because it's people at the end of their lives, and even at the end of their lives, people say, well, I can't talk to the patients about this because, you know, they're dying. And at the end of their life, people still want to make a difference. Involve them in it. Tell them that they can help people come along behind them. They can feel good about themselves as well. So it's a way of helping them as well. So do ask people, because as we heard earlier, they didn't mind a sample being taken, a mouse sample being taken every week if necessary. Do ask people. Okay, Duncan, you've got some more things to say about the research cycle. I've only
Thanks,
mentioned.
Alan. Yeah, no, that's brilliant, and thanks for the previous stories as well, and thanks for sharing those. I think it's important to acknowledge that, and I think, yeah, Alan's already picked up on the importance of involving members of the public in right at the very beginning, as early as possible, and designing, even prioritizing research questions, but also disseminating the findings from research. And although we're not disseminating a research study here, you know, you can see from Alan's contribution today, you know, how good a public speaker is at helping us to deliver. So it's a personal thank you for Alan to doing that. I like your acronym earlier, Alan, making a difference. You're not mad, but you are making a difference both to research and the delivery of this workshop. So thank you.
I'm not mad, but I like to do mad.
Yeah, exactly. No, I got it. Thank you. So I think we'll just, oh, well, there's a hand up. Claire, is that a hand for a question? Hello.
Yeah, sorry, I couldn't join at the beginning, but I just thought I'd pop on and say everything that Alan has said resonates. I also work as a public contributor. I work with the NIHR, the School for Public Health Research, ARC, and various organisations directly with their research teams. I've been a co-applicant, and I've seen what really good public involvement looks like. And only yesterday had an example of what less good public involvement looks like, where a grant application was due in at midday, and I got an email at 11:20 saying, can you review this? Actually, that's not integrated. It's not effective. It doesn't work. You know, we are there to be, I see my role very much as a critical friend. You know, we ask the questions that are more difficult for us to understand. You know, it's about supporting. We're on the same side as the researchers. You know, we're choosing to give our time up for this. And, you know, like Alan, my health background is very, very varied. I'm very fortunate to be here. And for me, it's a way of using those experiences to, to give something back, really. My professional background before I was ill was in communications, and I worked for a very large pharmaceutical group, funnily enough. But I don't have any kind of science background. Any science background has come through learning, through medical education, through public involvement, and through working with those teams. And for me, that's part of the benefit. You know, you learn from us, and we learn so much from you. And what that then does is develop our portfolio of knowledge and expertise for other researchers. And I think that that's a really key thing, that you do get some public, people will have not necessarily fantastic experiences of public involvement, perhaps, because some public involvement people won't be as committed as say Alan or perhaps me, and they won't do the work that is hopefully going to help you. But when you get people that are, it really makes a difference. And you know, I would say it's really worth investing in it, because the difference that it can bring, because as Alan has said as well, some of us have got experience of those funding applications. You know, I sit on funding boards as well. We know, we see those applications as they come in. We know what those discussions are about, what looks good, what looks less good, and how you articulate that. And I think that in order to, you know, in order to use that, just talk to us. You know, we would willingly share our expertise. And yeah, for me, it's changed my life. It really has changed my life. And that's why I kind of hijacked this this session this morning, because I believe so passionately in it that you know, I want to be there. I want to be able to support people who are, you know, who are perhaps less comfortable, you know, in taking the first steps into public involvement. Thanks,
Claire. That's good to hear. There's also some really nice feedback, Alan, for comments in the chat, saying how inspiring your talk has been. So thanks again, Alan. But we haven't finished. We need to move on to the next slide, if that's okay. Now, is that me even? I need to remind myself. No, it's not. Alan, it's back to you for how to meet. That's it.
Ah, yes, well done.
We'll get there. Thank you.
So how to meet with the public involvement group in person, use pre-existing or create new groups. You really don't have to invent the wheel, you know. There's loads of groups, as I mentioned, the cell crap one, and they don't like me calling it cell crap. It sounds a bit horrible, but I find it amusing. South East London Cancer Research Panel. But so use existing groups. You don't have to go out and mug people in the street and drag them in to be part of your PPI group. So online, Zoom and Teams, you don't have to go all around the houses for it, but you've got to take into consideration the patient's problems. You know, I'm going to give practical examples after this. So other ways of communicating: the phone, the email. Be mindful of people's time and responsibilities. Sorry. As I say, you can see I'm not that professional on this.
So, perhaps if we move to the next slide, that might be.
Next slide, yeah.
Yeah, that's fine.
Yeah, so this covers it a little bit more. So there's practical considerations, space and directions. What to talk about, you know, research ideas, public involvement, but space and directions. You might want to hold a whole meeting, but ask the patients that you patients and public think what's best for them. I mean, if you want to, your research is to do with old people, as myself, you know, is sort of over 77, you want to get them. Well, they don't want to travel before 9:30 because they'd have to pay for it, and then it will cost you, and they don't want to add to your costs. And so if you're calling him in for a meeting, sort of make it 10 o'clock or something, or allow time to get to a meeting. There's lots of practical things that you can do. And if you're holding a meeting and there's, you know, sort of 6 people coming in, have some coffee and tea and cake. I used to say, I only come here for the coffee and coffee and cakes when we go to a meeting, and it's a sort of fun thing. You're meeting other people. I enjoy meeting some nice people who are also giving up their time, so the patients, and so design it around the people, acknowledgement, the language you use, the materials you use. You don't want to get too technical with them. I mean, if people ask for the technicalities of your research, give it to them, you know, but we all, no matter what profession you're in, we speak a language after a while. You jump in and use acronyms as though everybody knows what you're talking about. So you know, right at the very beginning, I said the research ideas, just put it up there and just say, what do you think of it? Involvement process, getting people, and the ethnic issues about employing people. You're not really employing people, but have a recruitment strategy and patient information and the LACE. I've mentioned about the LACE summary and about the reading age of the age of 9. I can't stress how important that is, that you don't baffle people and you bring them along, and when you do get a result, you know, you get funding, tell the people and they say, oh, they take a little bit of pride in your success. We don't want to see you fail. I feel part of the team, you know. Once I commit myself, I try to understand the research and I read it through thoroughly, and I'm involved in it. So don't add us as an add-on. Try to let us know, dissemination. Send us an email saying thank you for something that we did, you know. Duncan's going to tell you he's going to give you money for PPI before your research is taken off. Before you've got any grant, he's going to give you money so that you can involve PPI. And sometimes PPI is just talking to people and there's not much money involved except your time. But at other times there's costs involved, and the patients, if they're coming in by train, you need the fares and things like that. Try to put yourself in the patient's practical examples of we jumped.
Well,
Yep.
why don't I pick up on that now, Alan?
Yes,
shall we? Because we've covered many of these practical examples already. So if we move to the next slide, it picks up directly on what Alan was just mentioning about funding, and I think this is me anyway. So
yes, yep.
it's
Done.
Thank you. Great, thanks, Alan. So yes, as Alan says, it's really important to budget, and as this slide highlights, to budget for patient and public involvement. Now we're trying to stress how important it is to involve members of the public as early as possible in the pre-design phases, and that's obviously a period where you're preparing a proposal, you're not submitted the funding yet, and you may not have a budget or some funds to do that early pre-design. Now, currently, the RDS does have a pot of funding called the Public Involvement Fund that you can apply for. All the details are in the slides in the handout when we send them to you. This is going to be dependent, or not dependent, but this is going to be influenced by the RDS ceasing to be operational after the end of August, but I will come to that in a minute. The main point I'm trying to stress at the moment is how important it is to engage with the early pre-design PPI and engage with the costings of that, so that you learn about the guidance that's out there. So the NIHR has got lots of detailed guidance for researchers, for members of the public, for organisations as well, updated fairly recently to take into consideration HMRC guidance on how to acknowledge members of the public in PPI activities. So, you know, we can point you to all this information, but taking into account and considering things like the travel, having a thank you, an amount. Sometimes it's given as a voucher, sometimes it is given as a payment directly to members of the public, so that you are acknowledging their input. Now, there are issues around benefits. Not everybody can receive either money or vouchers for that matter, and that's why it's useful to look at this new updated guidance that the NIHR has published. And sometimes people won't want to take the benefits. They do desire to give back. Now, it's very difficult sometimes receiving that as either a researcher or a professional working in this field like me, because you don't want to abuse that, obviously. But people sometimes say, I've benefited so much from research, I want to give back by giving this input, which is lovely, and it's a great thing to hear. But that doesn't mean to say it shouldn't be offered. And that can be monetary reward and recognition. But there are other ways of rewarding people and thanking them, and it's sometimes having a conversation with the PPI group that you may have convened to hear about what they might want. Maybe they want additional or help with CVs, and getting this experience of engaging with you would be useful to them, and they would see that as a type of reward. So there's other ways to look at that. But I think I've probably covered as much on there as I need to at this stage. But yes, so now, sorry everybody. So moving on to the support from RDS. So the update, which I highlighted right at the beginning by introducing this as the final RDS workshop, I flagged that the RDS service is closing. It will be ceasing to take new clients from the 30th of September. A new service funded by the National Institute for Health Research, NIHR, will be taking the place of the RDS, and this is going to be called the Research Support Service, so RSS. I'm not personally involved in the new RSS, and so much of the information that I have is limited, and the other colleagues helping today, I think, are in the same boat. But we have I think there's a link that's in the slides, but I think maybe my colleague Catherine can put something in the chat as well now. It's the NIHR announcement of the RSS. And I don't know as yet what the provision for patient and public involvement will be under the new RSS. So don't assume things are going to be the same. We don't know anything about workshops. We don't know anything about what will happen with the Public Involvement Fund. But if you are registering or have registered for support with the RDS, so the Research Design Service, if you do that by the end of September, the RDS will be able to support you with research up until the end of March. So we won't be taking any new clients after the 30th of September. Anybody registered with us by that date, we will continue to support until the end of March 2024. And you will be able to apply for the Public Involvement Fund, again, up until the end of September. We might be able to be a little bit flexible over that, but that's the only way at the moment to be eligible for that fund, whilst we sort of are still operating but closing down and moving to another service. Sorry, that's a bit long-winded and detailed, but I'm trying to get that across as simply as I can. But so there's links in the slides about how to access the information for the Public Involvement Fund. There is a brief form application form to complete. It's reviewed by the lay members of our RDS panel. It's not reviewed by me. I don't decide on who gets funding or not. It is the decision is given to our lay reviewers, but there is some important criteria, and the guidance is on the website. So I think Unless my colleagues suggest I may have missed anything, I think that's everything I need to update you on, both for the RDS moving to the RSS, but also linking that to the Public Involvement Fund. Are there any questions? I've bombarded you with a lot of maybe new information about the RDS and the RSS. If there's any questions specifically about that and the change, I'll do my best to answer. I don't know if I know much more. If there's nothing, we can.
Duncan, has the remit changed? The same.
Sorry, say again.
Has the remit changed?
The remit of
the new organisation.
Research Support Service is going to the only. Well, again, I don't know much. I know what is on the link, what is the information that's given on the link that's in the chat. The only slight difference that I'm aware of from the outset is, so currently the RDS is, as it says in the name, Research Design Service. Specifically, the main input is at the design stage of funding bids. The Research Support Service is at the design, supporting at the design and ongoing. Should the team be successful in securing funding, the RSS, as far as I'm aware, will be there to help provide support ongoing. Now, the RDS actually does do that for some projects already. So, I mean, that's a slight quibble, but that's all I know. Yeah. Are there any other things going into the chat that I'm missing? I don't think so. Catherine's got her hand up, my colleague Catherine. Hi, Catherine.
Sorry, I'm just working in the background today.
Not just important in the background. Thank you.
I was just going to say on the Research Support Service, just to extend on that question, it is actually meant to be a replacement for the Research Design Service and the Clinical Trials Unit. So as Duncan said, it will involve pre-award, but also quite a bit more of post-award support. It is going to run more as a national service, and there will be specialist centres, for example, social care, mental health and public health, meaning you may not necessarily, as you would now, be supported by your local RDS in the area in which you work. So if you've got a public health proposal, you may end up in the north of England or south central. So it's going to work more on a national basis. But as Duncan was saying, in terms of the public involvement offerings, we don't know the details per se of what each centre will be offering. I have seen people recruiting for ads though, so public involvement is still very much embedded into what they want to do. We just don't personally know what that's going to look like yet. But I'm sure more of that information will come to light as the service becomes established from the 1st of October. You can still go to the NIHR website and look at the spec for the RSS, and it's a very, very detailed and long-winded document, so I'm not going to put it in the chat today, but if people are interested and they just Google NIHR RSS, you can see what the full spec of that service was, if that's of interest to anyone. But yeah, just as long as you get to us by the 30th of September with all your requests, we will be able to support you through till March next year. Thanks.
Thanks, Catherine. That seems like a good time to have our break, actually. We're almost at 11:30, and we were going to take a 10-minute comfort break, go and make a cuppa, but invite you back with any questions you want to ask about the information you've heard today, any questions to Angeliki about her experience of PPI or her research, to Alan, if you want to ask him more as well. Come back with your own examples from your own experiences too, if you want. So I'll stop waffling and we'll see you back at 22, if that's okay. Alan, did you want to say something quickly before we?
Only that obviously, you know, an idiot like myself and an old fart, when you involve patients, sometimes it gets a little bit messy. As I say, you never know what's going to happen. The drugs company didn't know that I'd start a petition on Brown, who happened to be the Prime Minister's website there, and get publicity for them. They couldn't have sort of organised that behind, you know, it was just something patients have their own ideas about things, and they can help in ways you just don't understand. If you knew the ways, you wouldn't need public involvement, you know. But please, because as I say, involve people in the research, but it does get a little bit more messy, and another job for you to do. But that's all right. You're not employed enough anyway.
Thanks, Alan. Okay, let's take the break. I will pick up on questions that I haven't yet addressed from the chat when we come back at 22. Okay, lovely. See you shortly.
Well, that's good, Duncan. We got a few people stayed behind. They all weren't asleep.
I'm sure they're not. Yeah, no, it's going well. Well done. Hi, Angeliki. Nice to see you still.
Hello.
Hi. Yes, there's still about 16 people on the call, so some people have had to leave. But yeah.
I have a question for you, Angelique.
Yes.
I had a son die after 4 months of life with a sudden infant death thing, and I was really worried that if it's something I was doing, I wanted some sort of post-mortem, some sort of check on thing. It was 1979, and so but they said no, you know, they called it SIDS. It changed its name. It was sudden death. A campaign for study of infant mortality was a charity that I joined as a result of that, you know. But so they wouldn't have had those kind of tests, you know, to find out that the heart defects that you kind of had, the wall of your heart. I mean, it took long enough.
Did they do a post-mortem, Alan? Did they ever
subject
him? No. They
wouldn't do it, you know. I'm not sure why, you know. I mean, we had another child at the time, but I was just it's just that I was when I saw sudden death, I thought it was more to do with children, you know, babies, that when I saw your title coming up for the talk. So I was sort of geared myself to asking you a question, why they didn't do post-mortems or something like that, you know, to check.
So if I may answer your question,
yeah.
If the child was completely asymptomatic up to this point, yeah. So his lips didn't turn blue, if he was crying very intensely, he did not seem lethargic, if he was developing absolutely fine until one day he just left this world, then chances are, from what we know today, that he had something called Brugada syndrome. Brugada syndrome, yes. So this is the #1 cause of SIDS. First of all, I'm so sorry to hear that. I mean, I know it's been over 40 years, but it's something that will always haunt you.
Yeah.
It's if it is any kind of consolation, Alan, you too did not do anything wrong. It has. I mean, I know that people make a lot of suggestions to prevent this, keeping the temperature of the room between 20 and 22, and then only putting the child on his back, and then not swaddle him too hard, and sort of raise this to avoid the milk coming back up, and don't feed him and let him fall asleep on the breast before you put him down. So they have this list of crap, with all due respect. It's like these children, they are born with a mutation, with a change in their DNA, and they're doomed to leave this world before their first birthday. So there is absolutely nothing you did wrong. They don't aspirate, they don't overheat, they don't die because they're swaddled too hard, right? Their heart just stops. And even if they had done a post-mortem, Brugada syndrome shows no structural changes. So they wouldn't have been able to tell you, they would have named it SIDS with a structurally normal heart.
Thank you very much. I've never heard of that. I was obviously involved for quite a few years. When the next child came along, they put a Walkman on the side of it that made to do 24 hours heart monitors, and they did lots of things for the next child to put my mind at rest, you know.
Of course, yeah.
But, thank you very much for that.
You're more than welcome. Anything you need, do get in touch with me, though. Yeah.
Thank you.
If you want to chat more, I'm more than happy.
Thank you.
Thanks both. That's very. There's a hand up. Fran, do you have a question? And if so, do you want to speak it, come off mute and ask it? Can't see anything in the chat. Maybe Fran, that was an old hand. But Yes, Phil, anybody who wants to ask a question, just it's easier for me to see it on the video. So if you just put your hand up on the video and then come off mute and ask it. There was an earlier question put in the chat, Jackie. I wasn't ignoring you. Let me see. EDI, is it?
Yeah, thanks, Duncan.
Do you want to ask it? And then, because I can't find where it is.
Yeah,
now.
no, it was just really, I'm just very aware that we access the easy to reach people. And, you know, NIHR are increasingly asking us questions and requiring us quite rightly to have wider representation of researchers as well as our patient and public group. And I think we learned a lot through COVID, and it was very difficult to access people from that wider group in some of the projects that I'm involved in, because of perhaps mistrust of, you know, NHS and research and structures. So, you know, I'm really I try and exercise myself and thinking, okay, what could I do that's different? You know, these are people who may still be working, they have young children to, you know, compete with. They're very busy with life, and we do need to hear from them as well about, you know, the impact of some of the things that we do. So yeah, any ideas, tips, areas, groups that we can go to?
And I'm sure there's other experts on the call, so chip in. I mean, from my experiences, good PPI always starts with relationship building. Doesn't matter what the topic, doesn't matter what the project. You know, it's the relationships with the researcher and the members of the public. It's the member, if you're getting a group together of members of the public, it's the relationship within the group as well. And so reaching out, engaging, if your department or university or trust has an engagement office, which sometimes is not quite the same as the NIHR definition of involvement. It's often about, you know, informing the local community about the findings of the research that we do as a department. That's a good start. It's a good way of reaching out, of communicating research better, and you know, letting people know what's going on, to then have those discussions about what do you want next? What do you as a community want next for research? So that's a very general answer, but that's possibly a good start. And working with, I mean, I think the important thing to say about patient and public involvement and getting sort of a representative group is I bang on about this maybe too much, my colleagues tell me, and it may not be necessary this morning, but I will just come back to it to just stress that when we talk about representation within PPI, and I don't suppose you meant this, Jackie, but just to say it, that it's not the same concept as we use when we're talking and thinking about representative sample within a quantitative study, for example. So there's no need, because PPI is not research, you're not dealing with it in the same with members of the public in the same way. We're not recruiting them, we're not consenting them, we don't need ethics approval, we're not collecting data, we're not publishing that data. If any of the above is yes, we are, then you're doing research, but for PPI, you should not be doing any of those things. Then there is no need to think about getting a representative sample in the statistical sense. That doesn't mean to say we do not need a diverse, inclusive population within our PPI. We clearly do. And so the first thing to say is your PPI group needs to represent your target research population as much as possible. So if it is a topic that that you know the disease is known to affect particular communities in a particular way, then those communities do need to be represented in your PPI group. And if that's about reaching out via local community leaders, faith groups, other ways, other times and places where those groups are already meeting and piggybacking and creating those inroads and relationships that start having those discussions and building those relationships, as I say, then that could be a good way in. I mean, one group that is clear, that is very underrepresented, is actually children and young people. And even today, I think I'm right in saying that quite a lot of the drug formularies are still based on adult, dosages, whereas and they're just sort of rolled out to kids. There is a growing network of young people's advisory groups in research, and they're a great resource. But finding a group that may have the lived experience that you need for your topic may be challenging. And so then I would be saying, well, you need to maybe start recruiting your own children and young people's group that do have that lived experience. I think that is an important thing to consider. Getting lay input from a lay perspective of just being a member of the public is all good and well. So getting that lay input on a plain English summary, most people, person off the street, whatever, could possibly help you with that. When Alan's talked very eloquently about his lived experience, getting that lived experience takes more work to get members of the public who not only have that lay voice but have the lived experience of the condition that you're interested in. Will take more work to recruit that group. And I think there's a space for both groups, the general lay person plus the lay person with the lived experience. I think there's a place for both of those voices, but when the research is for the ongoing piece of research, you really do need that lived experience, and that's what the NIHR particularly like to see as well. I've gone off piece a bit there. When I mentioned, there is an important point though, I think, when I talked about and Alan addressed it when he was highlighting very early on about the distinction between what PPI is and what it isn't, and when people are recruited into your research as participants, they are clearly research participants, and you need consent and ethics approval. And it's something Angeliki highlighted as well, that you do not need ethical approval for undertaking patient and public involvement, and that's because of that distinction. You're not collecting data. Angeliki made a really good point. And said that you do still need to conduct your PPI in an ethical and sensitive manner, and I would endorse that wholeheartedly. So that's a really important point.
I think so. Can I say, Duncan? Yes, sometimes when you're asking people to give up their time, and it is personal and it's emotional. I think it's you always feel like you're taking something from them, and it's very difficult to say you're going to get nothing now, but thanks for your help, and walk away. I think that's the tension for me sometimes with that relationship.
Sure, and I guess, I mean, I don't want to just turn it into a monetary relationship, but I will just again say that that's what the PIF, the Public Involvement Fund, is really good at, because it does at least say we'd like to offer this, acknowledging also that some people may not want to. But I think building those relationships is about maybe what is it that they want to hear from you. So I was involved in a interpreting study many years ago now, and the community that we got together basically at the first meeting said, actually, we're really sick and tired of being researched on. Can you come and teach us about research? What is it? What is an RCT? How do you do a qualitative interview? So we spent the first 6 months giving them the teaching that they wanted, and then trained them up as service user researchers, actually, an area that we hadn't even considered initially. And they became service user researchers on the project that we initially wanted to get off the ground. But we did it in collaboration wholeheartedly with them, rather than, if we hadn't heard them at the beginning, we would have just been doing what they didn't want, researching on them again. So that's also, that is giving them something. I mean, it's not necessary.
No, that's really helpful. Yeah, no, that's good. No, I think that's a question actually to ask them. What do they want from this?
Yeah, and it might be totally unexpected. We had some people when I was at another university who said, "Oh, it'd be really great to get access to the university library. Could that not, we'd like to read more about this topic. We can't get the access to the journals at a normal library." And that some, not always, there have been issues sometimes, but a way can sometimes be found. And even, the Web of Science type access, that often isn't possible for a layperson, but some librarians are very, very good and can get the relevant appropriate email addresses and get lay people access to those sorts of resources. And it's not for everybody, but some people might appreciate that. Great. Karkit, nice to see you. I think you've got your hand up. Would you like to ask the question, unless I've missed it?
Yeah, yes, no, I haven't. Actually, there's also a question in the chat from Annie, but I'll ask my question as well here. So actually, something along the line of what Jackie just asked. So is this with I'm trying to apply for the patient involvement fund, and this is my first time organizing a PPI activity. I think I've heard in the past 2 hours, I've heard positive experiences from many of you. So I think my question is about, I think I have this fear in me that I may meet someone who is not very helpful or will make my job more difficult. So I'm just wondering how like, from any of you, what was your worst PPI experience, and if any, and how any advice you could give me in organizing or preempting any of these bad experiences that you have. Thank you.
Thanks, Karkit. I think I hear where you're coming from, and I think there could be some reticence out there among researchers, particularly those who haven't undertaken PPI, about, about people who may be difficult. I don't know. I'll say it, even if that's not the words you're using. I've facilitated groups where people come together with axes to grind, and they may very broadly have some relevance to the group discussion, but actually I found this in particular when I've tried to recruit members of the public from something like a PALS service, what's the A? Liaison service, patient advisory perhaps? But anyway, the PPI type groups that are within trust that specifically were set up to hear about experiences of service and clinical care. And sometimes, I think it probably is rare, but sometimes people have had bad experiences, and they use the PALS service to feed that back. So it may not be a good idea to recruit to a research PPI group from a PALS service, because if you just get people together who think they're there to talk about their bad experiences of care, that will hijack. It's potentially likely, I should say, likely to hijack your discussions of your research. So recruiting carefully, and it comes back to the lived experience of, and if your study is more statistical based, numerical, it's not actually a health condition, then I think it is the way in which the group is facilitated. Now, if sometimes a group works well with at least 2 facilitators, and there's ways and means of facilitating a group that gives those who seem to be reticent in talking the opportunity to come forward, but there's also equal skills in encouraging those who speak too much to speak less. Now, it's a whole realm of training. If you look at the focus group interviewer type training, those sort of focus group skills, how to facilitate a group, what role to take on as a facilitator, that might be useful. Or try and recruit another facilitator that could help you, or get yourself on some training that would enable, or shadow another group that would give you those exposure to those sorts of skills that you might need. I wouldn't fear, though, from the outset that will definitely happen. The unexpected will happen, and you're probably just as good at dealing with those as anybody else, but you can't obviously plan for those. But planning for for the difficult person or the difficult question, or perhaps it's you're fearing that they're going to take you down an avenue that you don't want to go in. Well, that's for you to feed back to them. Angeliki gave a good example of this, of she got some great feedback, some of which, yes, there was 2 examples she gave. The one that comes to mind to me is, sorry, Angeliki, I'm talking on your behalf, but the one about the anxiety and planning for mental health training for the nurses, that came out of that PPI consultation. Now, there were a couple of other feedback that, and I think Angeliki did well to get this in the proposal. You know, you're saying we heard also about this and this, but this isn't going to be possible for these reasons. Now, Angeliki is the expert in the field. She's aware of what can be done and can't be done. And members of the public, despite their lived experience, won't be aware of all the intricacies of the recruitment or the lab tests or whatever. And sometimes it is a no, sorry, this isn't possible. But it is good to say why it's a no, not just ignore it and say, no, that's a silly idea, because it's not necessarily a silly idea. It's just within the time scale, within the funding we're trying to go for, whatever it is, actually, that's not possible at this stage. I don't know if that helps, Kakit, or if there's anybody else. Annan, did you want to come in, Annan?
Yes, I did. It was only, I've never mentioned this before, but I did touch on the subject of how I wanted patients to feel at ease and that wanted to give everyone a penny. So I made an A4 sheet and I put one little paragraph, 3 lines saying that I've got your cancer, and I cut them all into strips to give out to people in the clinic. And I was, when they found out I was doing this, they said, "Oh, you can't do that." I said, "Well, why can't I? I'm just helping patients." And because I wasn't involved in research at that time, and they said, "We have to find out whether that's feasible." So we set up, it took about a year, and we set up patients supporting patients. I personally love the idea of old people supporting old people, children supporting children, and patients supporting patients. So it was a P with little s and a P, patient supporting patient. And when they was diagnosed, we had the idea that they would give them a card, a sort of postcard, and they could say, "Oh, I can talk to somebody who's been there, done that," and give them a sort of phone number. But we had to prove that it was okay. So it was very hard to, with my cancer, is pretty rare, only about sort of 600 people in the UK get it every year. So we picked breast cancer because there was a lot of breast cancer nurses and it was a big cancer, and they could talk to other women who had had breast cancer and survived and tell them some of the problems. And I thought this was a good idea. And I presented to a group of women that had womb cancer, and they were all, diagnosed as sort of as 4th degree kind of cancers. And they really destroyed my idea completely. They knocked me down, and I was out of my depth anyway, because I had other things I was doing at the time, and I basically gave up on that research, even though I'd got the money for the research. It was only 1,500 to see whether it was a goer, and I would, from Macmillan and Cancer Research UK, as you do, get the pool. It came out of the pool, and I only ever used sort of £100 on that, making these, printing postcards up to give out to people and recruiting the specialist cancer nurses. So, but that bad experience of PPI was just that one experience. It did have a big, profound influence on me, but that's in 16 years since I was diagnosed, and I've been involved, and I got more involved in a different direction. So it's been good for me, and hopefully it's good for researchers. But,
thanks, Alan. I've
realized it to be good.
I don't know if that helps, Karkeet. I've gone over time in my answer, and sorry about that. There is a question here, Annie, how big should a PPI panel be? I guess that is a good follow-up to what I was talking about to Jackie about representativeness or not, as the case may be for PPI. There is no hard and fast rule for this, so I can't tell you exactly how many. It needs to be, as relevant and diverse and inclusive as I mentioned before, pertaining to the lived experience of the actual participant group that you're researching. I think in short, there is maybe I'll just bang it into the chat here. There's I find it helpful. I'm not sure it's gonna, for those who want an idea of numbers, it may not be, but the HRA, so the people who go to for the ethical NHS ethical approval, Health Research Authority, have come up with 4 principles for meaning involvement. And they say principle 1 to 4. So number 1, involve the right people in your PPI group, involve enough people. So that's fairly general, but involve those people enough is principle 3, then describe how it helps. So they are the people who give you the ethical approval for your actual research. They've got a very good foundation and guidance on PPI that they expect in research. And I find there's more detail if you go to the website on each of those principles, but I think that I find it helpful. I don't know if that is helpful to any, though. I'm just going to put that in the chat. Yeah, so and sometimes it's as open as, if you start hearing, or you already know from the basis of previous research that's out there, that different populations have different experiences of this condition, then like I said to Jackie, then those different groupings need to be represented in your PPI group, either as a mixed group or as individual groups. So perhaps it's young people, perhaps it's older people, perhaps it's people from an ethnic background, whatever. So yeah, no hard and fast rules, I'm afraid, on numbers. We have gone over time. I'm sorry. Angelique's had to leave us early, or just a bit earlier. Sorry, probably at 12. I think I just want to reiterate that we will send the slides to you. Great. Sorry that I'm sorry, I'm going to have to move on and draw us to a close, but thanks ever so much for staying to the end. Thanks for attending. Thanks ever so much to Alan for your major contribution to this. You have made a difference. Thanks to Angelique also to the really helpful and interesting experiences of her PPI for her fellowship proposal. Okay, please get back in touch if you want to follow up on anything. Please register with the RDS if you wish to get support, and in particular if you want to apply for the Public Involvement Fund before the end of September. Okay, thanks ever so much. I'm gonna sign off now. Cheers. Bye.
Thank you very much.
Thanks, Duncan.